So it's my pleasure to introduce Dr. Heidi Reich. She is a cardiothoracic surgeon at our institution. It's been a great privilege to really work with her in the last year or so since she's been with us. She is absolutely superb and a leader in her field, and we're just thrilled that she is part of our Women's Cardiovascular Institute that we have here. So a little bit on Dr. Reich. She graduated with a bachelor's degree in biology from Reed College in Portland, Oregon. She excelled as a college athlete playing rugby, which I did not know. So I love when I get all these personal tidbits on our colleagues. She attended medical school at Emory University in Atlanta, Georgia, and completed residencies in general medicine, cardiothoracic surgery at Cedars-Sinai Medical Center in Los Angeles. She also received specialized training in aortic surgery at the Cleveland Clinic, which is the #1 heart program in the United States, with a focus on aortic aneurysms, dissections, and aortic valve diseases. She's a frequent contributor to peer-reviewed medical publications. She has a strong interest in innovation and improved quality, leading to numerous honors and special awards, including the coveted Nina Starr Braunwald Research Fellowship Award. It is a grant in honor of the first woman certified by the American Board of Cardiothoracic Surgery and the first woman to actually perform open heart surgery. It is such, I cannot tell you how proud I am to be on a panel of women today. In terms of women in cardiology nationwide, we make up about 12% of all the cardiologists. And I don't know the exact numbers of cardiothoracic surgery. Maybe Dr. Wright can help me here, but it's got to be less than that. And so what we're building here at community medical centers with a collaboration of UCSF is just a wonderful, robust center of cardiovascular care and excellence with a special focus on women. And it makes me very proud to be part of that. So Dr. Reich, we're anticipating and anxiously awaiting your wonderful presentation. So I'll have you start up, and then if you remember, put your questions in the QA session, and we will start QA as soon as she is done. Thank you.
Good morning and happy Saturday. I would like to thank Dr. Felice Lynn for that great talk, as well as the 2022 Women's Heart Fair team, community medical centers, and our Chief of Cardiology, Dr. Daniele, for the opportunity to speak with you about a topic that is near and dear to my heart. And Dr. Daniele, you hit on a really important point there. You're absolutely right. We need more women in cardiology and cardiac surgery. Around the country right now, about 7% of practicing cardiothoracic surgeons like myself, only 7% are women. And the majority of those surgeons are actually not doing heart surgery. So we hope that that will continue to change as we do more outreach to attract the best and brightest to our field and have a cardiac surgical workforce that looks more like the patients we're taking care of. As a matter of fact, I'm the only female cardiac surgeon in the Fresno and Clovis area. This morning, we will be discussing the heart of a woman, differences we see during surgery, with a particular focus on the blood vessels of the heart. As a participant in today's virtual event, you may already have a particular interest in women's heart health. You may already be aware that this month is a very special month. February is American Heart Month, and February 4th was National Wear Red Day, a special day dedicated to women's heart health. As this important month comes to a close, we are still hoping to build public awareness, to improve healthy behavior habits, and to ensure that research is inclusive. These points are especially important to me as a heart surgeon because some of the common themes I see in my patients that have important impacts on patients' outcomes and our goals of achieving maximal heart health. In that context, today we will focus on differences seen in women's hearts during surgery, with a particular focus on the important blood vessels of the heart. Let's go through the objectives of my presentation to give you an overview of what I plan to discuss and hope that you will enjoy learning about. Through this interactive virtual event, I hope you will recognize that cardiovascular disease is the leading cause of death for US women, but many do not realize that they are at risk. Heart disease in women may present differently than in men. But there is good news. Heart disease is usually treatable, and procedures are available to help individuals with heart disease get an accurate diagnosis for their heart problem, to survive, and to relieve symptoms. I will go over a few unique examples of cardiovascular disease in women to highlight heart disease symptoms, treatment options, and outcomes. The Go Red for Women's Heart Health team believes that losing even one woman to heart disease and stroke is too many, and that urgent action to increase awareness is needed. Each of you participating in the Women's Heart Fair today are in a position to rise to the call for action. Your efforts can make a tremendous difference. So how does heart disease affect women? First, let's start by dispelling a common myth or misunderstanding. Despite increases in awareness over the past decades, the CDC reports that only about half, or 56% of women, recognize that heart disease is their #1 killer. Let's review more facts about women and heart disease to get a better sense of the scope of the issue. Because many of my patients with severe heart disease did not realize they were at risk. Let's go over more women's heart disease facts that focus on the scope of the issue. Heart disease is the leading cause of death for US women. Heart disease takes its toll in all of our communities. And because heart disease is common and can be serious, preventing, recognizing the symptoms, and getting appropriate treatment is very important. 45% of women over the age of 20 have cardiovascular disease. Roughly 1 in 16 women, or 6.2% of women over the age of 20, have coronary heart disease, the most common type of heart disease. About 1 in 16 white women, Black women, and Hispanic women, as well as 1 in 30 Asian women in the United States, have coronary heart disease, which is also called coronary artery disease, and can lead to a heart attack. Next, we will go over this first example, coronary artery disease, in greater detail. Coronary artery disease is the most common type of heart disease in the US. It is caused by plaque buildup in the wall of the arteries that supply the blood to the heart, which are called the coronary arteries. Plaque is made up of cholesterol deposits. Plaque buildup causes the inside of the arteries to narrow over time. This process is called atherosclerosis and can lead to a heart attack. In 1977, my father's mother, my grandmother, experienced a massive heart attack in her very early 50s. My grandmother, Beth, lived in a small town in southern Washington, which is a similar distance from the next major city, Portland, Oregon, as the distance between Fresno and Tulare, for example, although her city was actually quite a bit smaller than Tulare. At the time, my grandmother experienced her first heart attack. The medical profession was in the very early stages of developing appropriate diagnostic tests and treatment options for coronary artery disease, which to me makes the story of her survival all the more incredible. Much of the pioneering work with coronary angiography to picture the coronary arteries, diagnose heart attacks, and to guide treatment decisions began in the 1960s and 70s. During the same time period, surgeons began performing bypass surgery as a treatment for coronary artery disease. No one in my family had a medical background or any particular knowledge of heart conditions. And my grandmother was living in a small town without sophisticated medical care. At the time, it was really not appreciated that heart disease was common for women, let alone for a young woman in her early 50s. However, against the odds, my grandmother was appropriately diagnosed with the heart attack she was experiencing and was transferred to a hospital in Portland, Oregon that happened to have one of our country's early cardiac surgery programs. Dr. Albert Starr, a name you might recognize because he performed the world's first successful heart valve replacement surgery, performed successful coronary artery bypass surgery to save my grandmother's life by using her body's own natural tissue to reroute the blood beyond where her blockages were to restore blood flow to the heart muscle. 9 years later, she is pictured in this photo you see here with a yellow arrow, having also survived breast cancer and a radical mastectomy, and having lived long enough for me with the curly red hair to have been able to be lucky enough to know her the first few years of my life. You may notice in this photo that she's wearing a high-collared shirt, so you do not see any sign of the scar on her chest, which I never saw either. By looking at her, you would never know she was a heart attack survivor. And even if she hadn't survived, I would not have had the chance to know her at all. It was a real blessing in my life to have been able to know my grandmother. Many women with heart attacks during that time were not so fortunate. And sadly, even in 2022, many women with heart disease symptoms continue to face obstacles in receiving an appropriate diagnosis and treatment. Within a year of this photograph, and 10 years after her life-saving surgery, my grandmother had a second heart attack that she was not able to survive, which leads me to ask, what can we do better to increase awareness of women's heart disease and to improve women's heart health? Women and men do share many common risk factors for coronary artery disease. Shared traditional risk factors include elevated blood pressure, high blood sugar, high cholesterol, smoking, and obesity. Importantly, smoking is an even stronger risk factor for heart attack in women than it is in men. And this difference in risk is even greater for women who are under the age of 45 years who are smoking. Smoking is the biggest risk factor for coronary plaque erosion, which is a particularly common mechanism of acute coronary syndromes or heart emergencies in women. Family history of heart disease, like I showed you in my family's history on that previous slide, particularly when a woman has a first-degree relative who is diagnosed with coronary heart disease before age 55 for a male relative such as a father or a brother, or before age 65 for female relatives such as a mother or sister, is also a significant risk factor for coronary artery disease. It's important to increase awareness that certain diseases that affect women, which Dr. Lin nicely highlighted in the previous talk, including endometriosis, polycystic ovary disease, diabetes and high blood pressure that develop during pregnancy, autoimmune disease, and breast cancer treatment do increase the risk of coronary artery disease. Thinking back to my own grandmother who had her first heart attack in her early 50s, I have to be honest with you. Although I was loosely aware that my grandmother had experienced heart problems, I really had not taken the time to ask about the details until relatively recently. And I mistakenly thought she had heart problems following breast cancer treatment and at an older age. And therefore, I was not particularly concerned that this meant that I might be at higher risk, which was incorrect. You may recall from my last slide that having a female relative with coronary artery disease before 65 can be a sign of increased risk. So I hope that you all can learn from me and from my mistake and make sure that we all do our due diligence to ask family about the details of their heart conditions so that other relatives can be more aware of if they too are at increased risk. Common themes that emerge from women's heart disease journeys, which I have seen in our practice here in the Central Valley, include that women with heart disease often present later in their disease course or may be referred to a heart specialist later with more advanced symptoms and disease severity. For many types of heart disease, the best treatment outcomes can be achieved with early diagnosis and treatment. It is important to acknowledge that there may also be relevant impacts of traditional gender roles. For example, women often juggle multiple roles, including the role of a primary caregiver, which can compromise their ability to seek timely care for themselves. This challenge has only been amplified during the COVID-19 pandemic, and it is of the utmost importance for patients and healthcare providers to recognize the symptoms of heart disease in women to avoid unnecessary delays in care. Next, let's discuss what are the common symptoms of heart disease in women. Although some women have no symptoms at all, others may have angina, which is a dull and heavy or sharp chest pain or discomfort, pain in the neck, jaw, or throat, pain in the upper abdomen or back, subtle symptoms that may be difficult to pinpoint. Symptoms may happen at rest or with regular daily activities. Women may have other symptoms, including nausea, vomiting, fatigue. Commonly, women have a tendency to downplay or misinterpret their red flag symptoms. Additional heart disease symptoms include that sometimes heart disease may be silent and not diagnosed until other symptoms or emergencies develop. Examples of such symptoms or emergencies include a heart attack. That may be characterized by chest pain or discomfort, upper back or neck pain, indigestion, heartburn, nausea or vomiting, extreme fatigue, upper body discomfort, dizziness, and shortness of breath. Heart arrhythmias can be characterized by fluttering feelings in the chest or palpitations. Heart failure symptoms, which Dr. Lin described so nicely, may include shortness of breath, fatigue, swelling in the feet, ankles, legs, abdomen, or the neck veins. If you have any of these symptoms, call 911 right away. So how can you go red? If you or someone you know is experiencing symptoms similar to the heart symptoms we discussed today, please make sure to discuss them with a trusted healthcare provider who can ensure you receive the appropriate diagnosis and treatment. If you sense something is not right, or you suspect you may have a heart condition, please speak up. Do not dismiss your symptoms. Trust your intuition. The best outcomes and the quickest recovery are often achieved through prevention and early treatment. A substantial portion of acute coronary syndrome cases, especially in women, are caused by mechanisms other than plaque rupture and blood clot formation. Plaque erosion, coronary vasospasm, and spontaneous coronary artery dissection, as well as stress-related heart failure or cardiomyopathy, are all more prevalent in women than they are in men. The top illustration here shows a blood clot formation on a ruptured or eroded plaque. In the middle is an illustration showing vasospasm, which is a temporary tightening or constriction of the muscles in the coronary artery wall that can compromise blood flow, and is also much more prevalent in women than it is in men. Spontaneous coronary artery dissection The bottom illustration, where the layers in the blood vessel wall become abnormally separated, also is much more common in women, who account for about 70% of cases. For our second example, we will talk more about spontaneous coronary artery dissection in greater detail. Spontaneous coronary artery dissection occurs when a tear in the layers of the coronary artery lead to a separation in the wall layers, which can compromise blood flow and cause a heart attack. This condition is much more common in women than it is in men, and is also linked to the hormone changes during pregnancy. Younger women are particularly at risk. This disease is underdiagnosed and misdiagnosed, often because a heart attack is not suspected in a young woman, even when the symptoms are classic or textbook. Overwhelmingly, these dissections occur in women who are often young, meaning under 50 years, and this disease is the most common cause of heart attacks associated with pregnancy. Over half of the patients who experience a spontaneous coronary artery dissection can recall a precipitating factor, which could include intense exercise, intense emotional stress, labor, and delivery during pregnancy. In terms of treatment options, dissected coronary arteries can be quite fragile. This makes angiography, stenting, and bypass surgery much more difficult. It is important to take women's heart disease seriously. Compared to men, women undergo intensive treatment for heart disease less often, even with symptoms that are just as severe. Women are less likely to undergo a standard treadmill test, which helps pinpoint heart disease risk. Women can experience vague heart disease symptoms that may be overlooked. In addition, women are less likely to be hospitalized when they come in through the emergency room with acute angina relative to their male peers with similar symptoms. Women who have had a heart attack are less likely to undergo an angiogram. Women are less likely to be prescribed important heart-specific medications, to be referred for revascularization, or to be offered cardiac rehabilitation. Each of these differences that I mentioned in the past couple slides are important factors that are known to impact heart health through clinical research that has shown that they are extremely important. Differences that heart surgeons have noticed in women who undergo heart surgery include: compared to men, women undergoing cardiac surgery are more likely to be older, to have additional medical conditions, such as diabetes, high blood pressure, having previously had a stroke, or having a low blood count or anemia. Women are more likely to require an urgent or emergent procedure, which can carry more risk. And women are more likely to have more advanced heart disease at the time of their surgery than their male peers. Collectively, these research findings suggest that women with heart disease may experience delays in their diagnosis and treatment for their heart conditions. These factors are likely to influence patient outcomes following heart surgery. And to me, they suggest an opportunity to improve health outcomes for women. In a woman's heart surgery journey, the steps include that she told a healthcare provider about her symptoms. She received appropriate tests to diagnose her specific heart condition. She was then referred to a heart specialist. She considered treatment options and which heart procedures would be beneficial. Historically, women have been underrepresented in clinical trials, which are the source of data used to develop treatment guidelines about the best possible treatment and standards. It's important for healthcare providers to be knowledgeable about special consideration for women patients and possible treatment or referral biases. I am so grateful my grandmother, Beth, was able to overcome some of these challenges, which must have only been exponentially more extreme in the 1970s, to be able to receive life-saving care for her first heart attack. Side by side, on average, a woman's heart pumps faster than a man's and pumps about 10% less blood volume per heartbeat. Relative to men, women can be more likely to have cardiac chest pain with a normal appearing angiogram. Angiograms are the specialized X-ray roadmaps of the coronary arteries. And this presentation in women can make getting an accurate diagnosis much more challenging. Compared to the heart of a man, women's hearts are smaller size with smaller arteries, including the aorta and the coronary arteries. Depending on body size, a woman with an aortic aneurysm or enlargement of the aorta may benefit from preventive surgery at a different size cutoff than a man. Smaller coronary arteries can make bypass surgery more technically challenging, which makes having a surgeon with experience in women's heart disease extremely important. During coronary artery bypass surgery, heart surgeons use the body's own natural tissue, the arteries and the veins, shown here with the arrows labeled bypass grafts, to reroute the blood beyond the blockages to increase the blood flow and thus oxygen and nutrient delivery to the heart muscle. Smaller blood vessels can make surgery more technically challenging, and this can impact the results of surgery. Compared to men, women undergoing bypass surgery are likely to receive fewer total bypass grafts during surgery. Incomplete revascularization, when not all of the coronary arteries with blockages are able to be bypassed, can adversely impact long-term outcomes for patients with coronary artery disease. As a woman's heart surgery journey continues, additional challenges can arise, some of which she may not even be aware of. Women who undergo heart surgery are less likely to receive optimal medical therapy, which is known through research to be an important component of achieving the best heart outcomes. Women who undergo heart surgery are also less likely to participate in cardiac rehabilitation programs, which are linked to the best heart outcomes. It is important for heart specialists to be thoughtful of these patterns and to ensure that important medications and therapies are not overlooked for their female patients. Your heart matters. Whether you're a man or a woman, it is never too late to lower your chance of suffering a heart attack. Let's go over some important steps so that you can have the best possible heart health and protect your heart. Quit smoking or don't start. Get regular exercise. At minimum, walk 30 to 45 minutes a day, every day. Eat a diet high in fruits, vegetables, whole grains, fish, and low in animal products, simple carbohydrates, and processed foods. Maintain a normal weight, a normal blood pressure, normal blood cholesterol, and normal blood sugar levels. Limit how much alcohol you drink. Find healthy ways to cope with stress. It's important for all of us to be proactive in reducing our heart attack risk. I wonder if some of these changes might have been able to help my grandmother avoid her second heart attack. Much of the information I shared with you today is available for your review at the American Heart Association website, heart.org. It's a really great resource for patients, family members, and individuals who are interested in learning more about their heart health and understanding heart diseases. I encourage you to take a look if you are interested in learning more. My team's website, shown here, myheartlungs.com, also has helpful information for heart patients. If you have a question about your heart health or would like to request an additional opinion from a heart surgeon about your heart condition, please feel welcome to reach out via our website or calling our office to request a consultation. Once again, I would like to thank Dr. Daniele, Dr. Lynn, the Women's Heart Fair team, and all of you at home for participating in our event today and for the opportunity to discuss these important heart health topics. I thank you all for your attention, and I very much look forward to your questions.
Thank you. Thank you, Dr. Reich. That was fantastic. And we will open up to question and answers. And after that, we'll take a small break because I know we've been sitting for a little bit and attentive to all these wonderful lectures, but we'll take a break in a minute. We'll open it up to questions.
Hi, everyone. I'm going to be asking a question from the chat.
Oh, sorry, Dr. Bala, your audio is echoing a little bit.
Oh, I'm sorry. Hold on.
So Dr. Bala is joining us. She is one of our internal medicine residents from the.
So the first question that from the chat would be, so we've talked about a lot today, and how difficult it is to make lifestyle changes. What is the first lifestyle change that would make the most impact for women with heart disease?
That's a loaded one. My goodness. That's a tough one. What I generally tell women is make changes that are sustainable. In other words, it does seem overwhelming if we say, eat right and exercise and de-stress and do all these kinds of steps. It's very overwhelming. So I appreciate your question because, which one should we target first? I'm going to say start in moderation and start moving, start exercising. If you can get physically active, that just the sheer activity level that you're doing, get outdoors and start walking, that will reduce your stress level. It'll keep you away from the kitchen. You'll stop snacking in the kitchen, right? And you'll start losing weight. There's benefits of blood pressure control, glucose control. So everything starts falling in line after that. I'd be curious to see what Dr. Lynn and Dr. Reich say, but I mean, there's so many ways you can tackle this. I would say start moving because everything snowballs after that, or escalates, I should say. But whatever change you make, remember, this is not punitive. People look at this as punitive sometimes in the office. They say, oh my goodness, I can't do this and I can't do that. I'll remember that being healthy and leading a healthy lifestyle is hard, but being sick and having chronic medical conditions is also hard. So I guess we get to choose what our hard gets to be, right? We have choices. So just keep that in mind, but I'd be curious to see what Dr. Lynn and Dr. Reich have to say about that.
Yeah, no, I think it's a loaded question. It's definitely very difficult. It's going to vary by the individual too, and just kind of what your lifestyle is. I think one of the easiest ones, I agree with Dr. Daniele. I think, trying to incorporate some kind of activity level, it can even be 5 minutes a day. And like I mentioned, just parking a little bit further back in the parking lots, walking into, grocery stores, doctor's offices, taking a flight of stairs, not 5 flight of stairs all at once, but just 1 flight of stairs, as a, just to get yourself used to it. I think those are great changes to do. I think if your life is already if it's a very high strung, high maintenance, perhaps, you got a lot of stressors in your life, then I would maybe even argue if that's the situation for you, that's probably what we should target first. And maybe it's not about moving. Maybe it's just, 5 minutes of just self-care, time for yourself, whether that's just sitting in a quiet room, no children, no significant others, just yourself. I think that's also something just as important. And then I think you can start incorporating all the other things too, whether, if you find that walking or just being outside by yourself without anyone helps with your stress and you're also getting some activity level there, then it's almost like a 2-for-1 there. So I don't know what Dr. Reich.
I agree with both of you entirely. And I think particularly for patients who are on a journey that includes heart surgery, walking is just so important. And like you both alluded to, you do kind of kill two birds with one stone when you incorporate regular walking because of the stress benefits. So I tell my patients that walking is really the best medicine for our heart and lungs as we're getting ready for safe surgery, and certainly while we're recovering from heart surgery. And I use that kind of as our starting point with a goal of 30 to 45 minutes of walking a day. And I emphasize because many of my patients have physical limitations that make walking challenging. I don't need them to run a marathon for me. If it is, 6 walks that are 5 minutes in duration spread over the course of the day, that's just as good from my perspective as one full 35-minute walk, whatever they're able to do safely. Or if we're in a place where we're not able to get up and walk, even doing range of motion exercises and getting our bodies moving in a seated or seated position, whatever we're able to do, we start somewhere. And then once we've mastered that, then I work with my patients to focus more on our diet and our medical therapies, thinking about the big picture as well, because in a perfect world, we would do all of these things perfect all the time. But as I shared in my talk, even some of the things that are important, like knowing your family history, I was getting an F- with that until about a week ago. So, we start with what we can do. Small incremental change is more likely to be sustainable.
Thank you so much
you.
for your answers. The next question from the chat is, with the pandemic, if people have gotten COVID, what are some known heart consequences of that?
Dr. Lynn, do you want to take that?
Yeah, I mean, I think the one we commonly talk about, it's not unique to COVID, but it's definitely put it to the forefront, is viral induced cardiomyopathy, or any kind of viral infection, any kind of infection really can cause heart failure. And usually, or even related to Takotsubo cardiomyopathy, kind of the stress of having an infection causes you to have heart failure or a weakened heart. The flip side of that too is also with COVID and with the infection or the viral infection, we also know it can cause heart failure through more of an like autoimmune system, where it's now attacking parts of the heart. And that's also another way to develop heart failure. I will say, there's lots of different types of heart failure. For viral induced or COVID related heart failure, it really depends on the situation for the most part. If I'm lumping it into the category of just, infections causing heart failure, they tend to get better. Usually, sometimes, actually, I don't even think I can say usually. Sometimes they get better with, medications, and kind of just the further out you are from that high inflammatory state. But it is a severe illness, and it can be so bad that it causes just a profound response in our body that unfortunately you may end up with, permanent damage, and may end up needing more advanced therapies, whether that's heart transplant or LVAD, which is an artificial heart pump. That's rare, but it does happen. But again, it's not unique to COVID, because this was happening before, but COVID has certainly put it to the forefront, I would say.
Thank you. And also remember, there's things that happen acutely when you're first infected, and there's people that have been showing up with blood clots galore, heart attacks because of blood clots in the lungs, blood clots in the arteries, and then more so longer lasting, where Dr. Lynn is talking about really injuring that heart muscle, leading to heart failure. So it's manifested in so many different ways. And to be honest, we don't even know the long-term effects of this. I mean, there's MRI studies that are showing scar tissue formation on heart muscles because of ongoing inflammation. So I think ongoing studies are still needed, but it can be anywhere from acutely blood clots to nothing, or a small degree of inflammation, or a lot of inflammation leading to heart failure and other sources. So I think time will tell as more studies come out to see what we're going to find. So for the sake of time, we can move on to the next question. So I know I want to make sure we get all of these questions, and we have about 20 of them. So we'll, Dr. Bala will go on to the next one.
So the next question from the chat is, what are the long-term consequences of heart failure? And to tie in another question, can diastolic dysfunction be reversed, and can heart failure be reversed in a sense?
Yeah, I think the short answer, for can diastolic dysfunction be reversed? It can. You know, and I think that's where some of the studies are showing that when you're exercising, when you're doing some of these things, treating all the other risk factors, we're noticing that the degree or the severity of that can improve. What are the long-term consequences of heart failure? That's a more loaded question, I will say, because it really depends, and everyone is different. I think that's where we don't know all the details of why some people react differently. You know, I focused a lot on diastolic dysfunction, the relaxation of the heart, and, you know, not so much someone having a weak heart. And I think a lot of my patients, when they hear that they have a weak heart, the next question is, well, how long do I have? Am I going to be out of here in a year? Like, what's going on? You know, because it just sounds so bad. And, you know, I think there's a lot of medications. So kind of splitting that question into two, I will say, if you have a weak heart, which again, I didn't focus on here, there's lots of medications, lots of different advances that we've had over the last few years that I would say we've certainly turned the corner in a lot of different ways for just longevity and also quality of life if you do develop heart failure. But it does take kind of, you know, it's not just us, it takes kind of the whole team to be able to get you to that point where you can still be active, you can still go about your daily activities, you know, still enjoy your quality of life. And I would say I have people who have had heart failure. I've known some people who've had heart failure for decades. You know, they've just done a really good job of taking care of themselves. You know, that, you know, it's not an issue. And, you know, so it doesn't necessarily shorten your life. But but again, you have to pay attention, you have to take care of yourself. You know, and I think even for diastolic dysfunction, we don't have as many therapies. For then, that's kind of why I focused on, you know, risk factor modification, you know, making sure that all these other issues that contribute to it are well controlled. But even with diastolic heart failure, we are having more studies and more information out there that we're noticing is helping in terms of improving symptoms, improving your quality of life, so that you don't have to go into the hospital. You can do a lot more. So I think long-term consequences, it just really depends, but there's so much advancement over the last few years. It's definitely gotten better, I will say.
Perfect, thank you.
Thank you, Dr. Allen. Another question from the chat, I think there's a theme on autoimmune disease in women and how that relates to heart disease. Specifically, one question was about pericarditis and what that would mean and for patients with autoimmune disease.
Well, I'll take that. I mean, remember when I gave my lecture about inflammation, right? Autoimmune diseases is a disease state where your body attacks its own blood cell, its own tissue, your own body inappropriately. It doesn't recognize its own tissue and it thinks it's foreign, and it causes a lot of inflammation of multiple organ sites or specific organ sites. Pericarditis is inflammation around the lining of the heart. There's a sac around the heart muscle, and it's inflammation around that. Many times, and there's a lot of things that can cause it. Most of these are caused by viruses. Some of them are caused by infections. Some of them are caused by, after heart attacks, and some are caused by autoimmune diseases. And so for that question in particular, chronic pericarditis and how it relates to autoimmune disease, it's basically chronic inflammation, just like your joints are swollen and tender from an autoimmune disease or rheumatoid arthritis. The lining of the heart is chronically inflamed. And that leads to, if not controlled, that leads to other bad things where we need Dr. Reich to come in and sometimes have to peel off that thickened, fibrotic, scarred over pericardium. Not a pretty surgery and not a good way to live. But for the sake of time, it's basically the way you treat it is, it depends on what the underlying thing is. If it's a virus, you treat it with anti-inflammatory and it should go away within a few weeks to a few months. If it's an autoimmune disease that's causing it, the important thing is to treat the underlying autoimmune disease. And once that is under control and your joints are no longer hurting, chances are the pericardium will stop being inflamed as well.
Thank you, Dr. Daniele. I think the next question would be a good one for Dr. Reich. Thoughts on cardiac rehab in the Central Valley? Who is eligible? Where can we go?
That's a great question. And, with the impact of the pandemic on our heart workforce in terms of our advanced physical therapists and our nurses, from 1 month to the next, which rehab facilities are open and accepting new patients has changed quite a bit. So there is a great need right now, at least with those pandemic-related resource limitations, to be flexible. I would say that any patient who is having heart surgery should be assessed for whether cardiac rehab is something they're willing to participate in. I tell my patients who are my most fragile, least mobile patients that it's extremely important. And I tell my patients who are high-performing marathon runners before surgery that it's still probably the best science-based way to get back to their full health. So whether you consider yourself to be someone who is quite deconditioned and not able to do much before seeking treatment for your heart disease, or someone who's actually functioning very well with their heart disease, I think it's beneficial for all patients who need an interventional procedure like heart surgery. And then for someone who maybe doesn't need heart surgery, but has advanced enough heart disease to be symptomatic in a way that's affecting their ability to do the things in their life that they want to do and that bring them joy, certainly there's a role there as well. So if you have a known heart disease condition, I welcome you to discuss with your trusted healthcare providers whether there would be a benefit to you participating in a formal program.
Thank you, Dr. Reich. So I'm sensing a theme in our questions, and a lot of them are based on preventative care. A lot of our attendees were wondering if there are any supplements that are recommended for women's heart health, and how can they come off of their cholesterol medications, or if you can ever come off certain medications that are started for heart disease, like cholesterol or aspirin.
So I'll take this one. I'll tell you, it's a common theme, or the panelists, it's also a very common theme that you see in the private office. I will oftentimes have patients come in with a whole list of 15, 20 herbal remedies that they would rather take than one medicine that is FDA approved and is paid for by their insurance company. And I say to them, let's take cholesterol medication. Cholesterol medication, the statin therapy, has been shown in many tens and dozens and dozens and dozens, if not hundreds of studies, to ultimately decrease cardiac mortality. Depending on the study you look at, it is anywhere from 20 to 35%. The way it does that is not only decrease your numbers, because you're right, you can do diet and exercise and decrease your numbers. You can do red yeast rice and omega-3s and all kinds of stuff, flaxseed, and lower your numbers. The difference between all the herbal remedies and the one statin drug is that statin drugs prevent you from dying. That's the main difference. It's not only about number control, because we often see patients come in with heart attacks with absolutely normal cholesterol numbers. And people say, my numbers are normal. Remember, it's not about just the number. It's about controlling that inflammation. Think about the statin as almost as an anti-inflammatory for the coronary arteries themselves, to stabilize them, to stop taking in cholesterol over cholesterol production in the arteries themselves. So when it comes to herbal remedies, there's no hard evidence that show that any of these supplementations will actually modify or decrease your dying, your mortality from cardiovascular disease. And if you look at the American Heart Association recommendations, American College of Cardiology, they put these herbal remedies in a class 3 recommendation, meaning there's no evidence that they've done anything to better our health, and they shouldn't be recommended. Now, if someone comes in and wants to take them and it's not harming them, more power to you. But I would urge you to take an FDA regulated, prescribed statin where you know you're going to stop the dying process, not just lower your numbers. So I will end with that. I mean, there's a whole host of herbal supplements and vitamins. I would go over it with your doctor to see, because sometimes, maybe the chondroitin that you're taking is good for osteoporosis, and calcium vitamin D is needed for osteoporosis, but not necessarily heart disease. So I would go over that list with your doctor. But when it comes to heart health, in general, we like omega-3s, right? Fish oil, but we know that everything over the counter in multiple studies has not shown and not found to make a significant difference in mortality. So you're flushing all these down the toilet. You really are. But I urge you to speak to your doctor about all the supplementations and curb it to what is absolutely necessary. Take that money you save and go take a vacation to de-stress. I think that's going to do a whole lot more than paying for all these special vitamins that you can take.
The one thing I want to add to that too is, like Dr. Daniele said, we're all about the supplements, but if you also focus on, supplements are there to kind of supplement what you take in, what your nutrition is, right? So kind of going back to the basics and remembering, if we really watch what kind of foods we're buying and we're cooking and what we are taking in to our body, then we may not need a lot of those supplements that they have there. And so I think that's one thing to really remember.
Agreed. Absolutely.
Thank you so much for that question. To tie in our next question to that, what are the panelists' thoughts on diets, including plant-based versus keto, Mediterranean? What do you feel like is a good diet for a heart-healthy patient?
Well, I think when you look at diet, I want you, before you start thinking of a diet, which I hate the word diet, right? I like lifestyle modification better. But if we're going to use the word diet, I want you to ask yourself, what are you trying to achieve? Are you trying to achieve weight loss? Are you trying to better control your diabetes, your blood sugar numbers? Are you trying to achieve lower blood pressure readings? Are you trying to achieve lower your cholesterol? Are you trying to do an anti-inflammatory diet, right? There's so many different things. So you need to first focus on why it is you want to modify your diet. What is the problem? What are you trying to achieve? And then you can tailor your modification based on that, because there is no one diet fits all, right? There is a better way to overall consume our dietary intake, but then there's all kinds of preferences, right? There's vegan, there's vegetarian, there's all kinds of things. If we look at cardiovascular lifestyle modifications, looking at diets, the colleges of the American College of Cardiology and Heart Association will recommend the Mediterranean diet, which is the only diet, by the way, to have studies that show that will actually increase your life expectancy. The only one out there. And the reason it does that is it decreases cardiovascular mortality. You die less from heart attacks and strokes. And the other one that's recommended is the DASH diet, DASH, which is actually shown to decrease your blood pressure, and that's by eating a low sodium diet. So that's where I would start.
Thank you so much, Dr.
You're welcome. And my goodness, it looks like we are out of time. How many other questions do you have, Dr. Bala?
I was going to do one last question for the panelists and then close our Q&A session. So the last question, I think, was an interesting one coming from one of our attendees. If we're on a statin and we're having side effects like muscle cramps, what would be the next step? Do we stop taking the statin, or are there other medications, or what would be the next step?
I can pitch in. So yes, that is definitely a common side effect of statins, unfortunately, with muscle aches, and it can be fairly serious. But, I would say that we do actually have other options in terms of medications that we can do besides statins. They are different. They're a little bit more novel in terms of the way we get them, because what I'm specifically thinking about are going to be our PCSK9 inhibitors. These are injections, actually, as opposed to a pill. The risk of, muscle aches, myalgias, still unfortunately there, but I think a lot less compared to statin therapies. And, we think about injections, we're probably thinking, oh my gosh, I have to inject myself every single day. The one nice thing I would say, or the manufacturers did think about this. They did, with the PCSK9 inhibitors, it's once every 2 weeks. There is actually a newer drug out there by Novartis, where that one's actually going to be like every 6 months. But again, that's one of the newest one that was just recently FDA approved. So there are options, but you do have to weigh the risk benefits in terms of injections and some of the issues with that. But based on some of the trials, we do know, for the most part, they seem to be well tolerated as well.
And if I can just add to that is, don't give up on statins. For number one, we don't want you to live your life in pain. So please work with your doctor, because sometimes it's just a matter of lowering your dose or changing one statin to the other. Please do not anticipate you will have pain. I have a lot of people that come in and say, I have 2 friends that have pain. I don't want to start it. This is a life-saving drug. Think about it that way. It's a life-saving drug. Please approach statins in a positive light. We do not like to push pills. We like to give you medicine that will save your life. And so be proactive about it and give it a try. If I could put it in the water supply like fluoride, I would, because remember, heart disease is the #1 killer of both men and women. It affects 1 out of 3 of us. And we do not want to be that person. So be open-minded, but we don't want you living in pain either. So talk to your doctor about this. So I think we're out of time for questions. I'll quickly go through the chat, and if there's anything I can text you in, text you or put in the chat quickly, I will. Thank you so much to our speakers, Dr. Lynn, Dr. Reich. I really appreciate you being with us here today to celebrate our 8th annual Women's Heart Conference. I really hope we're here in person next year.